And it's because of that interest and that, understanding of women that are going through this, that, I'm trying to figure out why women miscarry. I have a clinic that does just that. I'm helping other physicians understand what it is that we do. So I'm thankful for my journey.
Both Mary and I, as you may know, struggled to conceive. And I went through multiple miscarriages, had an autoimmune workup, which we'll get into in today's podcast. And it turned out that I didn't have an autoimmune condition they could discover through blood work. But I always wondered, is there something going on? Why was I having multiple miscarriages? And a lot of patients want to know about why their transfers are failing if they're doing a frozen embryo transfer. Perhaps they have had multiple miscarriages and they're trying to investigate, like, what is going on? Is there an autoimmune condition or is it down to the egg? And Mary, also, you have had that history of multiple transfers, then went on to have a healthy baby, as did I. But did you ever wonder, right, if you had some kind of autoimmune issue going on as to why the 5 transfers didn't work?
Yeah, well, I mean, you hit the nail on the head. The thing about, do you wonder? Well, don't we wonder all the time? Yeah. Because when something doesn't work out, I don't know about you, but the automatic, and actually they say it, whether it is, there's a failure, right? Like an implantation failure.
Right.
That's the terminology they throw around. And it's very easy for us as women being vulnerable to really blame ourselves. And also it's like, then what is wrong with me? So we're going to look and see if there's some kind of pathological issue that has us be in our position. Short of, oh my gosh, am I a bad person? And this is just not happening because I did something bad. Right.
Right.
So,
right.
Yeah. And it's not that, guys. It is not that. I say this with my heart and soul, and it's like, it has nothing to do with you as a human being. And sometimes there can be things that are being triggered in your immune system, and it might be a good thing to check out, but that's not necessarily all the pieces. So we brought in Dr. Genevieve Genest, and like, seriously, we are so super honored. And I don't know if you know this, Tanya, but she has never done a podcast before. And I spoke to her. Yeah. So it's her
fantastic.
Because she speaks from the heart. She knows her stuff. She is literally the expert. I was at the Canadian Fertility Andrology Society annual meeting. It's a handful, a mouthful, but basically it's all the fertility doctors are there learning from other scientists. She was one of the speakers, and she is the head of this first immunological reproductive program in all of Canada. And she's the head of it. So we are like in for a super treat. You guys like need to listen to this all to the end. And she is so freaking phenomenal. And she comes at it from a human experience, not just as a physician, because she herself had 3 miscarriages. So amazing.
What I loved about listening to her was she really broke it down for us and gave us the juicy details. I guess you like to call it juicy, and I now do too, in terms of like the real stuff, like what works versus what is just hearsay. So like, which autoimmune protocols have some science backing them and assessments, and what's real versus what's kind of just being experimented with right now. And I love the statistic that she gave on 70% of women who have 2 miscarriages go on to have a healthy baby. So listen to that statistic. I know I said it once, hear it again to help you stay motivated to keep going. And there are some really interesting facts on progesterone, stuff that I didn't realize. So, and how much that helps, and a few other interesting facts. So I think that this was a phenomenal episode, and I'm shocked that she was, this was her first podcast, because she did excellent. She was wonderful. So here.
Yeah. So, I mean, when we're in this place of vulnerability, isn't it true that, we question ourselves, but then we may even question the integrity of a physician? It's like, are they just telling me to do all these kinds of tests and taking me all these things so that they can grab my money? I mean, I know that is there because people tell me,
feels like a money grab. But at the end of the day, it's all about intention and intent. The intention for these physicians, these specialists, are to get you pregnant. They're trying to do, get you pregnant in the least amount of time with the least amount of money spent. They're not trying to do a money grab, but even though it feels like it. Oops, that sounded funny. Yeah. Money grab.
Yes. Well, and that is so correct because, they can be scratching their heads too, because the truth is, there is no current treatment that is proven and effective for recurrent miscarriage or implantation issues, right? There's nothing totally proven, but there's a lot of great studies right now that kind of points towards. So she led with that. And, we found, both Dr. Tanya and I found out about progesterone. So some people will say, hey, do I really need to take progesterone? And how she puts it, it's like, oh my gosh, like maybe it's a great first line of defense or first treatment, right?
Yeah. It lowers the immune system and supports implantation. And we didn't realize, the two of us, the impact that it really had on the immune system. We were more focused on supporting implantation and how it can really reduce risks of miscarriage. So yeah.
So, we would think of it as like the thickness of lining versus also the immune component. So have a listen. We know that you'll love it. And if you don't, DM us and tell us that, but I am sure we are pretty clear that you'll get lots out of it.
If you love this episode, like and subscribe, and please share, because the more viewers and listeners we have, the more likely we will have people hearing our podcasts and more people will be educated. So please share, subscribe.
Initially, we were going to talk about two separate things, which was recurrent pregnancy loss, so multiple miscarriages, separate from people who go through IVF and have implantation failure when they do, for example, embryo transfers. And right before we went on, you said, but Mary, it's really part of the same continuum. So we can go take a deep dive into all of this together. So let's go straight into it. And we know that miscarriage rates are really high. And 50% of women who go through repeated recurrent pregnancy loss, it's like unexplained. So what do we do? And we would love to hear your thoughts around this and what you do to help women.
So, you have to remember that as a human species, we're really bad at reproducing. So from studies that come in the 1970s, we know that around 2/3 of all human embryos are not good. So they're either genetically normal or morphologically, or they don't look normal under the microscope. So, if you have one miscarriage, it's okay. And around 15 to 30% of all human pregnancies will end up in miscarriage, depending on maternal age. So depending where you are on the spectrum, 1 or 2 miscarriages is okay. It can happen. It's not necessarily everybody's reproductive journey, but it can be yours. And your live birth rate, even after 1 or 2 miscarriages, is upwards of 70% on the next pregnancy. So these are all things that we have to remember. And it's very possible that we never find out why you had a miscarriage, 1 or 2 miscarriages. We don't usually investigate because it's very low yield and we're not usually going to find an answer. When we start worrying is, patients that have 3 miscarriages. At that point, we start investigating. So we start looking into, is there a problem with the uterus? Is there a problem with blood clotting? Is there a problem with the endocrine or hormone system? Is there a problem with genetics? And then, if we don't find anything, as we don't in 50% of cases, then usually we'll ask the patient to change her lifestyle, maybe prescribe some aspirin, some progesterone, and then wait and see for the next pregnancy. But when we really start getting worried is after 4 or 5 unexplained miscarriages in an otherwise healthy woman. That's when we start thinking about other things, especially when we haven't been able to find the source. And what we're thinking more and more about is the contribution of the immune system to either implantation failure or infertility or repeated miscarriages. So just to give you, I guess, a bird's view of what I do, the immune system is very, very important for a normal pregnancy. And so every single menstrual cycle, you're going to recruit this huge amount of immune cells to the superficial layer of the uterus, which is called the endometrium. And those immune cells are basically going to be told what to do by the endometrium itself. And those immune cells are going to take on characteristics that are very different from what we have in our blood. And they're basically going to constitute the uterus's own immune system, which is actually there to help accommodate a pregnancy. So the uterus's immune system is there to recognize the embryo, to help the embryo implant, and to help that embryo form a placenta. So if you have a defect in that process, it can easily explain why you have infertility or why you have repeated miscarriages. And basically what we do in our clinic or in my clinic is that we look at patients that have had, 4 or 5 miscarriages or maybe 4 or 5 IVF attempts and still have not had a viable pregnancy or even a pregnancy. And we try to figure out, is the immune system, playing a part in this by trialing different medications to change the immune response. So that kind of in a nutshell is what I do in my clinic. I don't know if you want any more details.
Well, so I loved how you brought that in terms of, it's not just about miscarriage. It's also about what the heck is happening when people are doing repeated IVFs and there's no implantation happening. And so when would that juncture of time be, like, after 2 times of, they do genetic testing on the embryos and they're deemed normal, and yet they've had 2 or 3 failed attempts, they do not get pregnant. Do you jump the gun and say, oh my gosh, this is surely an immune issue? Or what do you think about that?
So not necessarily, because you have to remember that we know very little about the endometrium. We know very little about endometrial receptivity. And we don't have diagnostic tests to diagnose all of these different possibilities. So unfortunately, immune-mediated miscarriages or immune-mediated infertility is going to be a diagnosis of exclusion once you've ruled out everything else. So, after 2 failed transfers, honestly, it can be normal because it's a numbers game with IVF. Every single time you transfer an embryo, you have a 40% chance of live birth, 30 to 40%, depending on maternal age. And as you age, that chance gets lower. Even with genetically normal embryos, maybe we'll have a 50% chance live birth per embryo transfer. So again, it's a numbers game. So after 2 failed attempts, it's okay. Let's try again. But it's really after 3 or 4 that I'm going to start worrying, especially great quality embryos, especially genetically normal embryos. And those are the types of patients that will start thinking, okay, maybe something's up. And then especially patients that might have an autoimmune background. Maybe someone in the family has lupus or rheumatoid arthritis or some autoimmune disease. Maybe the patient has had autoimmune symptoms in the past. So, we kind of look at all of these factors to try and figure out whether the immune system really is playing a part or no. But we really don't get a diagnosis in most of the cases. We'll say that the woman had immune-mediated miscarriages or infertility if she responds appropriately to treatment. But we never really have that confirmatory test, which we're working on now in the lab, yes, but it's really just not available right now.
So when you're talking about testing, let's go over some of this, because there are lots of available testing and it can be so confusing. As you know, this journey is so tumultuous and it really touches your emotions, and it's really difficult to think straight. It's like, how much should I do? How little should I do? How much intervention should I have? What tests, right? So, I know there's the ERA, there's like Alice and Emma, and, and we'll go through some of this if that's okay with you. And then, and then share with us what you think. Actually, I think we need to dial it back to the very basic, because you did this amazing, like really, honestly, the best spoken lecture at the Canadian Fertility Andrology Society ever. I go every year, and other people had said the same thing. And so you mentioned that, progesterone can actually be a thing to help moderate the immune system. So I thought, wow, I only looked at it as like helping the thickness of the lining, but I never really thought of it in such a way about immune modulation. So can you explain that? And, that is probably like the first line of defense, right? Like the first course of action. Right.
So, you have to bring it back to the immune cell. So right after ovulation, there's this huge influx of immune cells to the endometrium. And those immune cells, they don't really know what to do. They have to be told what to do and how to act. Because again, the immune cells in your endometrium are going to be completely different than your blood. And the way that they adapt to those conditions is by being told what to do in the environment in which they're in. So as soon as they get to the endometrium, they're going to be bathed in, many different molecules, one of those being progesterone. And progesterone actually acts on those immune cells to tell them to change just a little bit so that they can take on their pregnancy-specific roles. So when we're talking about progesterone, in terms of an immune standpoint, it's really only going to have a beneficial effect if it started prior to pregnancy, if you're having implantation failure or really early losses. But progesterone is a great medication to prevent miscarriages anyways, because it has so many other effects. Like you're saying, thickness of the endometrium, maybe possibly endometrial receptivity. But in terms of the immune system, again, it really has to be started prior to conception or as soon as possible, as soon as the pregnancy is diagnosed.
Which is so great because, for those of you listening and watching, this is where you go and self-advocate, because if that's not happening with the care that you're getting, get your doctor to listen to this or watch this and have them see that it's beneficial, done properly, right? I mean, it's one thing taking something, but done appropriately at the right timing, that's crucial. So, yeah.
But even we have studies in recurrent pregnancy loss, and this is pretty widely accepted, that progesterone for patients with repeated miscarriages is probably the only thing that's been shown to decrease the miscarriage rate and enhance the live birth rate in subsequent pregnancies. So, it's not something that costs a lot. It's not something that has many side effects, and it's something that can be potentially very effective as a first-line therapy.
So the other first-line therapy that we talk about is low-dose aspirin. So is that a proven one? Is this something that you advocate for? Tell us a bit more.
Yeah, I use it a lot in my practice, but you also have to be careful. So there are certain patients that just won't be able to tolerate aspirin. So for example, those that have easily upset stomach, those that have a lot of acid reflux, patients that have already had bleeding episodes, those are not necessarily candidates to aspirin therapy, but most of the time aspirin can be introduced relatively safely, 1 baby aspirin per day. This can be done prior to conception for patients with recurrent pregnancy loss, and there is some scientific data to back this up. The only problem is that the studies are very difficult to do. So when you're doing studies, basically you want to study one group without the intervention and one group with the intervention. But when you have a medication that's available in the pharmacy, a lot of those patients that are attributed to the no intervention group will just go to the Shoppers Drug Mart and buy their own aspirin. So the studies, again, are very difficult to do, but we do have some good evidence that aspirin potentially does decrease the risk of miscarriage. But again, it probably has to be adapted to certain patients. I don't think everybody is going to benefit from it. But, just carefully selecting the patient population, I think we'd find that aspirin is much more beneficial than we think.
So the bottom line here is that each individual is an individual and that we should be treated as such versus let's do a generic treatment. Let's just give you progesterone. Let's just give you aspirin and away you go.
But we don't have the tools to do that yet. So I think we're getting into the era of precision medicine, and we do have a lot of tools available to us. But again, it's how do we use those tools and how do we develop those tools and how do we validate those tools afterwards? The idea of personalized medicine is fantastic, but we need to be able to figure out what we're measuring and how to measure it, which we're not quite there yet.
Right. And even with progesterone, isn't it difficult to test because, you're looking at it through the blood versus in the uterus? Tell us a bit more about that.
Even just talking blood versus uterus, coming off the topic of progesterone, if you're going to do any assay on the blood, it's not necessarily representative of what's going on in your uterus. Because again, in terms of the immune system, they're two completely separate immune systems. So your uterus is really there to accept an embryo and help it implant, whereas the immune system in the blood is really there to defend you against any invader, bacterial, virus, fungus. So it's really not the same immune system. So if you do a blood test and look at the immune system in the blood, it doesn't reflect whatsoever what's going on in your uterus. So I'm tying back to what you were saying before in terms of, fertility patients or recurrent pregnancy loss patients. There's so much information out there. There's so much testing out there, and you can easily spend thousands and thousands of dollars on, tests that aren't necessarily validated. So one good test that hasn't been validated is immune testing through the blood. And then in terms of progesterone, I completely agree with you. Measuring progesterone levels in the blood is one thing. We're able to do that, but then we're not able to measure its effect in the endometrium. So even if you have someone that has a very high progesterone level, you don't know what that progesterone effect is in the uterus. And we just haven't figured out how to measure that yet.
So in that person with high progesterone in the blood levels, then you'll still confidently say, you know what, let's just use progesterone.
I don't measure progesterone. I know some people do, like the practices vary a lot. And that's because, everyone has kind of developed their own expertise. I have colleagues that I respect tremendously that use progesterone levels to figure out which doses of progesterone to give. And, they're experts in their own field. I don't use it because I don't know how to interpret it. And I don't know, there's a lot of things that haven't been validated. So if you're taking kind of like a lump population that has had recurrent pregnancy loss, really the cornerstone treatment really is going to be intravaginal progesterone for me. Okay. Regardless of the progesterone levels.
Even from lab to lab, they change the ranges, and sometimes they're reevaluating those ranges and, scaling back. So it's hard to interpret even as a practitioner if you are somebody who tests. So that makes a lot of sense.
And again, it's okay to test,
of course.
And you've probably developed, whoever tests have probably developed their own practice in that way and has figured out what works and what doesn't work. So, there's what is in the science, what is in the literature, but there's also a huge part of personal experience and how you've treated your patients in the past and how you've succeeded in doing so. So again, every one of us has our own little tricks.
I think patients will often push for testing because they want to know to make sure, because they don't really necessarily always understand the pure science behind it to see, okay, I want to make sure I'm not exceeding the ranges. But again, if the ranges used to be up to 80 and now it's 40 and they're between 40 and 80 and they're doing it to prevent recurring pregnancy loss, then it makes sense to say, okay, well, even if you fit into this high end of the range or outside the range, we're going to do this anyway because the literature proves otherwise. And it's more looking at how you managing the progesterone. Is it giving you side effects and then scaling back? It makes sense.
Yeah, exactly.
How about steroids and intralipids? And is there major science behind using that? Major science.
I wouldn't say major science, because the problem with reproductive immunology, and we're going to bring it back to a population level, is when studies are done, you basically lump everybody together in the same boat. So you say, okay, everybody with 2 or more miscarriages, we're going to give you one thing. And then there's another group that's not going to get anything. And then we're going to figure out, who has more live births. But the problem is you're not selecting the patients that are most likely to benefit from immunomodulatory therapy, which is your intralipids and your steroids. And we still haven't quite been able to tease that out. So if you take, a population of 100 women, and only 3% of those have immune-mediated pregnancy loss, you're not going to see the benefit of your treatment in those 100 women because you're not pre-selecting those 3% that might benefit from your treatment. So the problem with all of the studies that we have is, since we don't have a diagnostic test to figure out whether or not my patient has immune-mediated reproductive failure, we're not able to streamline those patients into the personalized medical approach, which is ideal moving forwards. So in terms of immunomodulatory therapy, there's many, many different kinds that are out there. Personally, I do use steroids. I'm very careful with steroids. They have many, many, many side effects. And we know that if we use them for the entire pregnancy, we have worse pregnancy outcomes in terms of more preterm birth, more preterm labor, smaller for gestational age babies. We have much more maternal complications like diabetes, hypertension, even maybe cleft palate for babies in terms of congenital abnormalities. So you have to be really, really careful when you're using steroids. They can be very effective for a select few patients, and they have to be used at the smallest possible effective dose for the lowest amount of time. So usually I'll use steroids in a patient that is, for example, with recurrent miscarriages, I'll use steroids in a patient that gets pregnant really easily. And I'll usually start the steroids before she gets pregnant. So I'll usually start it after her ovulation. And I only use this for patients that get pregnant within 3 months. And then I continue the steroids up until the point of previous loss and then decrease them very gradually. In terms of intralipids, I don't use them personally. I just haven't been convinced of their efficacy quite yet. So basically what intralipids is this fat emulsion. And the reason that we're using intralipids just historically is because at one point it was used as a placebo in another study that was looking at immunomodulatory therapy. And they were able to see that in the intralipid group, patients were having better outcomes than in the other group. So that's how it was being used to prevent miscarriage. But ever since then, we've never been able to show that intralipid reproducibly increases the live birth rate.
Wow.
So, again, there's a lot of therapies that are out there, and you really do have to do your research, because if somebody proposes them to you, you have to make sure that you fit within the category, that it really is indicated for you, and that you're doing so in a safe manner.
All right, so let's do a little listing then. How about embryo glue?
Oh, I have no idea. I'm not an embryologist. No idea whatsoever.
How about immunoglobulins?
So actually,
IVIG.
use a ton of that.
Okay.
Yeah, we use it in Quebec. So we had a program running for a long time, for about 5 years. We were giving women with at least 4 to 5 miscarriages, at least 4 to 5 embryo transfer failures. And we were actually having, 60 to 70% live births with IVIG. The program
So explain what that is exactly.
So intravenous immunoglobulin, what it is basically it's a collection, it's a blood-based product, and it's a collection of antibodies from over 10,000 different donors. So you need a huge pool of donors just to get 1 dose of immunoglobulin. So as you can imagine, during the COVID pandemic, where not many people were giving blood, we weren't able to access it as easily, and the whole stocks of immunoglobulins were being used for patients that really needed them. So basically what we think immunoglobulins do is kind of reset the immune system. Basically what they can do is they show the body how to become tolerant to certain proteins, and they decrease the level of activity of the immune system, which is what we think is doing for recurrent pregnancy loss and recurrent implantation failure. Intravenous immunoglobulin is exceedingly expensive. So we're talking probably right now $300 per gram, and we use an average of 40 grams per dose, and we can use 1 dose per month up until 20 weeks of gestation. So, we're talking about $20,000, maybe even more. So here in Quebec, we've been able to get the indication for IVIG to be covered by the RAMQ in very select patients. They have to fit, very strict criteria. They have to be evaluated either by myself or by one of my colleagues who's doing the same thing as I am. But it's definitely not something that we can use for everybody after 3 miscarriages. You have to have failed several lines of treatment, and have to have had, a high order of miscarriages. We're talking 5 or 6 before being able to access that type of therapy. So we usually try other methods, other less expensive methods with less side effects. So for example, yes, prednisone, we're talking first lines. So progesterone, aspirin, definitely. Sometimes we even use low molecular weight heparin. So these are blood thinners that also have an effect on the immune system. Sometimes those help out as well. We've been using a molecule called hydroxychloroquine, which maybe if you remember, before the COVID pandemic, President Trump was very enthusiastic about that medication, thinking it would cure COVID. Does absolutely nothing for COVID, but it seems to help some women with recurrent pregnancy loss. And there's 2 ongoing randomized control trials. So we're actually using that. And then apart from that, I use intravenous immunoglobulin. And then there's a whole other slew of different immunomodulatory therapies that are out there as well.
So like LIT, I know some people are still using that, right?
Yeah. So LIT, it's based on the fact that when someone has an allergy, so for example, a tree allergy or a dog allergy, because I'm also an allergist, one of the ways that we improve their symptoms is by giving them something called immunotherapy, where basically we give tiny doses and we increase the dose every single time until the patient is able to tolerate that allergen. But basically what we're doing is we're telling the body, stop attacking this one thing, it's okay. But it takes about a year for us to get to that point where the patient is going to be desensitized, and we have to keep on that therapy for about 3 to 4 years, actually 3 to 5 years, for that patient to truly maintain that desensitization. So LIT is based on that principle, that introducing very small amounts of a foreign protein in incremental doses will eventually make you gain tolerance over time. But it's based on a faulty premise, because the allergic inflammation is very, very, very different from the immunologic inflammation that we see in pregnancy losses or in implantation failures. So applying what works for one type of allergy to pregnancy loss is, I'm gonna use stupid, but I'm
just
sorry,
say it as it is. Absolutely.
I'm saying it as it is. It doesn't work. There's many side effects. There's nothing that's been validated in the literature, and it's incredibly expensive.
Yes,
and it's not well done. So, those kind of therapies really get my blood boiling, because you're taking a very vulnerable population and you're proposing them this great therapy that costs a ton of money that really does not work. And that comes to that. Anyways, I'm not a huge fan of the LIT, and it's actually not been banned in North America, but several different authorities have come out against this type of therapy. Remember that if it's not done in a controlled lab, and if the partner hasn't previously been screened, there's risk of HIV, hepatitis B, CMV transmission. These kind of things are not benign.
Oh, you know what? We didn't actually explain what LIT is.
Sorry. LIT is lymphocyte immunotherapy, where basically they take the partner's white blood cells and inject them subcutaneously, so under the skin, into his female partner, so that she eventually gains tolerance to his proteins. But again, it's not the same proteins that are expressed in the white blood cells as in the seminal fluid and the sperm. You don't have any white blood cells in the sperm, or at least you're not supposed to. So again, you're inducing tolerance to the wrong protein, to the wrong antigen, and you're basing yourself on literature that's been validated in a completely different condition. So again, LIT,
really thank you for this, because I know that this will make a difference, because people that have the ways and the means, they will go to something like Mexico and get it done. So hopefully this will stop that. And I know we're running out of time, but I would love your input on what your thoughts are around other ancillary services like acupuncture or supplements and lifestyle changes with regards to all this. Like, bring it back down to being more simple into your life.
Yeah. Well, I mean, you also have to ask yourself, why is, maybe we perceive that there's more infertility, because it's still 1 in 6 couples in Canada, and 2% of births are from an IVF procedure. And in terms of miscarriages, maybe we're talking more and more about it, but it seems to be more and more frequent. But if you bring back to the statistics, we're still at around the same 15% per pregnancy. But the other thing that we're not talking about is our lifestyle. We're much bigger than we used to be. We're not as active as we used to be. We're not as physically fit. We don't eat as well, and there's a ton of processed food. So, could that potentially be playing a role in infertility and miscarriages, or our decreased reproductive success? I don't know. What I can tell you is that certain women are going to go to huge lengths to, eliminate gluten, eliminate dairy, eliminate transformed foods, completely eliminate alcohol and coffee. None of that matters to a certain extent. If you're eating McDonald's 3 times a day, that's not a good idea. But if you have a well-balanced lifestyle, you don't have to put all of these restrictions upon yourself. Being a patient with recurrent miscarriages or a patient going through infertility, you have so much stress already that you don't need to be stressed about your diet. So as long as you're eating, your 5 to 10 recommended fruits and vegetable servings, you're eating whole grains, as long as there's not too much processed food, a normal diet, I think you're fine. You're allowed to drink coffee. You're allowed to drink alcohol from time to time. Like, you do have to think about yourself sometimes, and food makes us feel good.
And unless you actually have food sensitivities.
Absolutely. Right? So, I mean, if lactose or gluten makes you feel bloated and gross, like, just cut it out. You're going to be miserable anyways. But you're not doing that for your fertility. You're really doing that so that you can feel better going through it. Weight, though, is very important. So if you're obese, so we're talking, body mass index over 35, there are calculators that are available where you put in your height and your weight, and it's going to give you a number, which is your BMI. So if your BMI is 35 or over, you're obese. And that is associated with an increased risk of miscarriage. So what, studies have shown us is that if you're obese with a BMI of 35 and over, your baseline risk of miscarriage is 25% over what is expected for your age. So say, for example, you're a 30-year-old and you get pregnant, your baseline risk of miscarriage is 10 to 15%. But tag on, obesity with a BMI over 35, and you're at 45% risk of miscarriage. So, all of these things do matter. Having a healthy weight does matter. Exercising regularly does matter. Maybe stress does play a role. We'll never know. But what you have to tell yourselves is we're all stressed in 2022. And women in war zones are able to have children. So, stress is probably an important component, but not as important as you think. And in terms of, a holistic approach to fertility, I think it's a must. I don't think that as a fertility patient, you can go through your journey without, being taken care of as a person. And medicine can only bring us so far. We can only explain, so many things. We can only have treatments for so many things. And other approaches are really there to kind of complement what we do in medicine. Acupuncture, I think, unfortunately, without being able to do studies, and this is just more from a personal experience, really puts the patients more at ease because they get into that acupuncturist's office and they're completely taken care of for, 30 minutes. Nobody is going to give them that much attention. And, I don't understand acupuncture. I'm not going to, even pretend to understand acupuncture. But what I know is that when these women come out of their acupuncturist, they feel better. And, whether or not that has an incidence on implantation or miscarriage, I have no idea. But if you can go through your fertility journey and you feel like you're being taken care of and you feel that someone is taking the time with you for even half an hour once a week, like, for me, that's enough. And I have to tell you, in terms of acupuncture versus no acupuncture, the women that are going through their fertility journey with an acupuncturist seem much more zen. That's what I've observed. I don't know about acupuncture. I have to read more about it. But that's at least what I've observed. So, you have to have someone accompanying you in your fertility journey that's not just a medical doctor. And that's more for your personal sanity as well. Because your partner is going to give you only a certain amount of support. Your friends are only going to give you a certain amount of support. Society is not going to understand what you're going through, because I think only someone who's gone through what you're going through is going to understand what you're going through. But really having that key other person that can kind of help you in your fertility journey and accompany you non-medicinally, I think is definitely key.
So, and I can hear it in your enthusiasm, and what we would like others to know is that you yourself understand this conversation because you had recurrent pregnancy loss. Right?
Yeah. So I had 3 losses before I was able to conceive. So I have an 8-year-old and I have a 4-year-old. I'm very glad that I had miscarriages in a sense, because I never would have been propelled into this type of career. The only reason that I got into this career is because of personal experience and because this happened to me. When I saw a patient in the clinic with one of the physicians in allergy who was a recurrent miscarrier, I said, hey, that's interesting. We're using this therapy to help out with these miscarriages. This makes no sense. This blows my mind. But it's because of, that history that I got interested. And it's because of that interest and that, understanding of women that are going through this, that, I'm trying to figure out why women miscarry. I have a clinic that does just that. I'm helping other physicians understand what it is that we do. So I'm thankful for my journey. But I also think that we have to, as women, other patients that have fertility problems or miscarriages, we have to talk about it, because I think that's the problem with being a patient with fertility issues or recurrent miscarriages. You feel so lonely. You feel like you're the only person on the planet that has these issues. You don't want to talk about it because you don't want your story to get out, or for whatever reasons, but just talk about it. You'll maybe make someone feel better. Maybe someone will make you feel better. Start the conversation, because this shouldn't be taboo. We're in 2022.
I agree. And so that's why I really honor you for sharing your story, because it's pertinent, because this is life. Yeah. We can't have them all in separate silos, separating your work from your personal life, trying to conceive and build a family. So we really want to thank you for that and your time, because I know you're crazy busy right now. Is there any last words? Actually, 2 questions before you go, if that's okay. What was your biggest challenge while you were trying to conceive?
I think it's probably failure, because at the time that I was having miscarriages, I was in residency. We were very busy. I understood the science behind it. So, I knew that I'd be okay. I was young. I had a great ovarian reserve. I knew a lot of physicians. So I already took those stressors out. But for me personally, is failing at something. I had never failed at anything in my entire life, or at least not that significantly. And I felt, women are put on this earth to do one thing, and it's being able to reproduce and have babies. And I was failing at the fundamental thing that I was supposed to be able to do as a species. So for me, I grappled with that. Obviously it's sad, but all of this, the memories that I have from that period of my life is really mostly failure and, letting my partner down. I think it's mainly that was my biggest challenge.
And do you still see it as a failure?
No, it's
thank you.
Yeah. So, what I learned over time is that you have to start seeing fertility and recurrent miscarriages as a chronic medical problem and addressing it as such, because it's not normal for a woman to have 3 miscarriages. It's not normal for a couple to be infertile. There's a medical explanation behind it. And just because we haven't been able to figure it out as a scientific community, it doesn't mean that something is not happening. So, it's not a failure. It's a medical problem. And the failure in terms of, I guess, recurrent miscarriage or infertility is that we haven't figured it out yet as a scientific community. So I think we have to take that burden off of women and put it on people like us, where we have to do the research and we have to figure these things out and we have to do the appropriate studies. And all of these things are being done. It just takes some time.
Well, and I think it's beyond even the medical community. I mean, it's globally. I mean, look at the quality of our food, all the toxins in the air and the quality of the water, plastics in the ocean. That has to amount to something.
I'm sure it does. Yeah.
Right. Like we don't really know. And so we can't just now put it all on you or I or Tanya. Like, this is now our things to solve. Right.
We also start to have to look at the males. So there's more and more literature, and we're not doing that. Well, now we're starting to, but an obese woman can have many miscarriages, but so can an obese man.
Yes.
And how competent is his sperm? He has to make some lifestyle changes. Stop smoking cannabis, get on the exercise machine, start walking, stop taking as much calories. At one point it has to be a couple's effort, reproductive fitness. Sorry.
I was just going to say, and that's even if his sperm analysis shows up normal.
Yes. Yes. Because there's so many things that we can't diagnose with a spermogram. All we're looking at is the sperm able to wiggle? Can it go in a straight line? Does it turn on itself? And does it look abnormal? That's the only thing that we get from a spermogram, but we have no idea what's inside the sperm. Is it able to communicate with the egg? Is it able to release its genetic information? Is it metabolically normal? Is it able to function? We have no idea.
And lifestyle has so much to do with it. And I can't tell you how often, still to this day, even though that they were looking more to men, to this day, lots of fertility doctors will say, oh, the sperm looks great. And then it's like they're absolved from doing anything at all. And then they go home and the woman is pissed.
There's nothing to do, though. There's nothing to do. What can we do?
Well, what can they do in terms of their own lifestyle if they're still smoking pot and if they're still smoking and drinking and eating pizza, 5 days a week, like, I mean,
But if you have take away all of those things and you still have, a normal fit male who's still not able to get pregnant with his partner, something else is happening.
Yes,
it can still be a male contribution to that. But the problem is we haven't quite figured it out, and we don't know how to treat them to help with the reproductive success. So, there's so many unknowns, and it's very easy to get kind of lost. But as you're saying, you do have to be your own advocate, but you also have to trust your healthcare providers as well.
Yes.
And there's sometimes, unfortunately, a lot of mistrust. There's, patients that'll go from clinic to clinic that'll get different opinions, peg doctors against each other. And that's also very difficult to deal with as a medical subspecialty. So
then what's your takeaway? Like, people are, like very interested in this conversation, and we're learning lots here. But what's your biggest advice to the people that are here?
I think it's, you have to take some time for the couple. You have to take some time away from fertility. I know it's much easier said than done, but at the end of the day, the person that you're with, you chose that person for a reason. And it's very, very easy to lose that person in this whole process. And two people deal with grief, because this is what recurrent pregnancy loss is and infertility. It's, grief over and over and over again. And it's these high peaks of emotions and, low troughs of emotion. And, people deal with that in very, very different ways. And it's very often that the couple will lose each other in all of that and blame each other for things, or, not want to say things because they don't want to hurt the other person. So you just have to be very careful of that. And you really have to take care of and nurture your couple when you're going through this, and try to stay sane as a patient. Do things that you enjoy. Whether it's yoga, going hiking, or taking the dog for a walk, it doesn't really matter. You have to find those little pockets of joy, because the journey is long, the journey is tough. And, as a medical specialty, we don't have all the answers. No one does.
Yeah.
And the takeaway is really that it's take care of yourself and take care of your couple. And it's easy to get, basked into this infertility drama, which it is, but you can't stop living. You have to, make your career go forward. You have to keep up with friends. You have to keep up with your partner. So just don't lose yourself in this fertility journey, because you don't want to regret that later.
Thank you so much for that. And I do want to add in then, because you mentioned about stress, and we just released a podcast about stress with Dr. Julia Sen. So you guys need to go back and listen to that. And in 2 weeks, we're actually interviewing Alison Armstrong. I don't know if you're familiar with her, but she wrote the book called The Queen's Code. And we're super excited because it's all about relationship, intimacy, because doesn't intimacy and sex get totally lost when you're down this road, right? So it's really important to build that relationship. So we're super excited to speak to her as well.
Oh, that's great. I'm definitely going to tune in for that.
Yeah, for sure. Thanks so much for your time. You're like, I have 30 minutes and here we are at 40 minutes later.
Yep. I will
go eat some
catch
lunch.
up somehow. Well, thank you so much for having me.
Okay, take care.
All right.
Bye. Okay, guys, thank you so much for tuning in. And as Dr. Genest, I have to say, she was, it's her first time doing a podcast with us. And she is phenomenal. When she was speaking at the Canadian Fertility Andrology Society, she had a standing ovation. And I'm telling you, there was a giant lineup of fertility doctors waiting to see her. So this was super special. You're getting the real goods. And I know there's more to ask, but, perhaps we can get her back on. And if there's questions that you may have that you want covered, please, you could write it down in the comments below from this live Facebook post. You could DM me at Meet Mary Wong on Instagram, or go to myfertology.com and check us out there. And Dr. Tanya and I will take care of this. Have a great day, and we shall see you real soon.